Good evening, everybody, and I welcome you to this ASCO ISMPU Joint Symposium. You've already heard Dr. Everett Wokes talking about their initiatives as to how they want to reach out to rest of the oncologists across the globe. So my talk is specifically going to be the problems that we face and how we have tried to make some innovative solutions to help our patients. So to understand our problems, we need to know what is the magnitude of the problem that we see. And we all understand that there is a clear difference between the trends in cancer mortality and the causes between the developed and less developed countries. Just to give you some numbers, it's estimated that the cancer mortality in more developed countries is projected to decrease by about 30% by 2030. But during the same period, in the less developed countries, the projected increase is by more than 70%. And it's estimated that by this time, 85% of all cancer deaths will be occurring in low middle income countries. And we all do understand what is the cause for this. This is largely contributed due to delay in accurate diagnosis, lack of awareness about cancer and the potential value of therapy, ability to access and get the delivery of potentially curative treatment, and most importantly, abandonment of therapy. Now, looking at the risk factors or the causative agents, these are some of the 8 important ones that account for almost 50% of deaths from cancer. Tobacco use by far is the largest, H. pylori, alcohol, hepatitis B and C, low intake of fruit and vegetable, essentially low intake of antioxidants, human papillomavirus, physical activity that is decreased, overweight, and obesity. So as you can see here, there is a differences between the high income country, middle income, and low income countries. And this is important for us to look at strategies to tackle these problems. Now, a little more about the cancer scenario in India. There are about 1 million new cancers detected every year. 3 to 3.5 lakh die every year due to this. And this is statistics again, looking at the 500% increase in cancer in India by 2025, and 280% will be attributed to aging population and 220% due to tobacco use. So this is staggering numbers for us. Now, on the other hand, we have less number of qualified oncologists to treat patients. And this is just to look at the comparison of qualified oncologists to the population in millions across different areas. And as you can see here, for India, it is less than 1. Of course, this number is slowly changing because we have more and more doctors getting into oncology today, and hopefully this will increase in the future. So this is looking at number of new cancer patients per qualified oncologist. And as you can see, the variation across different areas, and we have India here. It is 835. Of course, there are other countries which are worse off than us, but I think, again, this needs to change. And let's see what we can do towards this. Now, this is the geographical map that we are all familiar with. And but if you actually see the map as per the human population, it's staggeringly different from this. And this is important for us to understand, again, the problems that we have with respect to cancer and other non-communicable diseases. So that gives a lot of food for thought, and let us see how we can tackle some of them. So the first thing is that we need to look at the complexity of cancer head-on in smarter ways, which could be looking at more basic research, very specific to our region, smarter clinical trials addressing our specific issues, increased population diversity in research, and more efficient biomarker validation. We know that there is difference in biomarker in the populations, and this is important for us to remember. The second one is to leverage the information technology, especially in our region, which is pretty resourceful with the IT population. And we need to have the data from each patient, not just from clinical trials, what we call the real world data. And also support oncologists in decision making through artificial intelligence and machine learning. And this, I think, is happening very rapidly, especially in areas of diagnosis. Look at quality improvement and assessment as well. And the third one is to expand both knowledge and means to access high quality care. We know that there are huge variations in developed countries. Basic tools are often out of reach. And the major gaps, as I mentioned, is in the oncology workforce. Cost is always an issue, which is becoming an issue even in the Western world today. The other things we need to focus is patient reported outcomes, a lot of emphasis on patient palliative care and the survivorship issues. So with these important things, let me look at what in our region we have done to address some of these questions. The time is too short for me to give you all the answers, but some important ones I will go through. So I'll be touching upon what we have done with generics. As you all understand, India is the pharmacy capital of the world. We have generics, biosimilars. We talk about metronomic chemotherapy, supportive care, drug repositioning, some things on diagnostics, capacity building, and monitoring as well. So I'll give an example in non-small cell lung cancer because this is an issue here as well. And one of these papers that we published way back in 1993 in Lung India, this was looking at the pharmacoeconomic benefit of cisplatinum and etoposide for metastatic non-small cell lung cancer. This was days when EGFR was still less understood, and the regimes that were popular at that time was etoposide, paclitaxel, gemcitabine, pemetrexed with a platinum backbone. And this is the mean and median PFS with the various chemotherapy regimes. So just to show you the survival functions, the patients who got etoposide plus cisplatinum did just as well as the other regimes. In fact, if you look at the cost, at that point of time, pemetrexed was a monopoly across the globe, and it was pretty expensive. And we showed with this paper that use of cisplatinum and etoposide was just as good as the other regimes. And this was important for our part of the world. This other paper, which was led by Dr. Parikh et al., which we published in 1996, is when gemcitabine just came in. And again, this was an expensive drug. What we showed with this paper was that low dose prolonged infusion, looking at the drug scheduling, was in fact possible. And this led to a response rates of 68%, which at that point of time was the best reported in the world, and a whopping decrease in the cost by 66%. So soon we understood that we need to look at our lung cancer patients differently. And today we are actually looking at molecular selection for patients, which has led to dramatic outcomes with survival for these patients. So the story is of evolution of tyrosine kinase inhibitors. This is just to tell you that from gefitinib, we have come a long way today. We have the third generation osimertinib and dacometinib, and we have understood a lot about these drugs. But again, for a region like our country, osimertinib, the cost is an issue. So this is a very nice paper published from Tata Hospital, our own place, presented at ASCO 2019, looking at combining gefitinib with pemetrexed carboplatin. And they showed that the median PFS and overall survival was in fact much better with gefitinib and pemetrexed carboplatin. In fact, the overall survival at the time of reporting was not yet reached. So showing you that we do have innovative ways of trying to help our patients with the limited resources that we have. So this is another paper which we published quite some time back, looking at nimetuzumab, which is an EGFR monoclonal antibody. And we showed that adding monoclonal antibody with the chemotherapy, the response rates increased to 60% as against about 38% for the chemotherapy arm. And this we published in 2014 in the OncoTargets therapy. This is another pilot study that we have done, looking at combining minocycline with tyrosine kinase inhibitors. And the concept was that minocycline was being used to treat the TKI-induced rash, and incidentally, they found improved survival. Further research led to the understanding that minocycline inhibits PARP1, and EGFR mutated tumors are deficient in this path, and therefore that could lead to synthetic lethality. So we did a small study, and this is a survival function showing you that for gefitinib, the median PFS was 9 months, whereas for the combination of minocycline and gefitinib, we had not yet reached the median PFS at 15 months. So this we presented at ESMO 2019, and we'll soon have this publication as well. So I think this is a very innovative and a cheap method of trying to help our patients. We do have a lot of generic Geftinib and minocycline is available. So it seems a very cost-effective way of tackling our metastatic EGFR mutated non-small cell lung cancer. Now, coming to the question of treating breast cancer, we are all very familiar with how hormones affect the breast. And we do understand that with subsequent lines of therapy of hormones, there is an incremental decrease in the outcomes that we see because of various resistance mechanisms that set in. So understanding this, in 2009, this study was done combining letrozole plus everolimus to overcome the resistance pathway that was induced by mTOR pathway. And this showed that adding everolimus increased the clinical benefit to 33.4% as compared to 18% for letrozole alone, to exemestane alone. So I must recollect Dr. G.S. Bhattacharya, who actually started this concept, trying to look at reversal of tamoxifen resistance by addition of sirolimus. Sirolimus is an mTOR inhibitor, much less expensive as compared to everolimus, and this has been used by our nephrology colleagues for a long time, and we know its safety profile. So this paper was actually presented in the proffered paper session in ESMO 2012, where the same everolimus paper was presented, and there was a lot of discussion on this. So I think this is another innovative way of using this. And what this paper showed was that the clinical benefit rate was 62.1% when sirolimus was added to tamoxifen versus 14.4% for tamoxifen alone. Dr. G.S. Bhattacharya, I think we must give him due credit. He has been always thinking out of the box. And this is a paper looking at continuous low-dose temozolomide with a combination of etrutac and propranolol. And this actually has actually got a orphan drug designation for propranolol and etudolac for treatment of malignant glioma. And this is the orphan drug status given from US FDA. Now, coming to other important issues that we face is an oncologic emergency. We talk about tumor lysis syndrome. And many of our patients do come with advanced disease, and this is an inherent threat that is there. So we published this in the European Journal of Hematology in 2018, looking at the pre-phase treatment prior to definitive chemotherapy in diffuse large B-cell lymphomas. So what we showed that by giving weekly vincristine and steroids, we were able to decrease the percentage of neutropenias, be it any grade 3 or 4 or febrile neutropenia, by a large extent, as shown by the green bars as compared to the red bars when we started these patients with prephase. So that is, again, an important thing that we are routinely using it for our patients who come with poor performance status or a very bulky disease. The other important issue that we have always been talking and many of us are practicing is the metronome and chemotherapy. I don't need to go into the details about how these metronomic chemotherapy brings about therapeutic benefits. And this is the differences that we have as compared to the conventional chemotherapy. And there's a paper that was published by Vijay Patel et al., who looked at triple metronomic chemotherapy in recurrent metastatic head and neck cancers. And they showed that this was in fact good, and it was promising, and it needs to have further studies done. So this metronomic chemotherapy became important, especially during the 2019 pandemic, where patients were unable to reach to the hospital to get intravenous chemotherapy. And this is a paper published from All India Institute showing you this very important way of trying to tackle with metronomic chemotherapy. Now, a word about the other drugs that we have been having. This is about the Rituximab, one of the first biosimilars made across the globe by one of the Indian companies. And we were a part of the study which compared the original Rituximab with the biosimilar here. And the conclusion from this study was that the biosimilar was as efficacious as the originator in terms of response rates, progression-free survival, and overall survival with comparable toxicity. And mind you, this is a 5-year follow-up study. And this we published in 2013 in the Journal of Medical Pediatric Oncology. Nausea and vomiting is an important issue for most of our patients. So we did a study looking at how we can reposition olanzapine as compared to aprepitant. And this was a study we published in Chemotherapy Research and Practice in 2016. And the conclusion was that there was no significant difference between olanzapine and aprepitant in preventing nausea and emesis with highly emetogenic chemotherapy. In fact, nausea was better controlled with olanzapine, and there was some drowsiness with this. So what we decided was to give this drug at night, which will help them to take care of their sleep as well. Now, the difference in cost, aprepitant costs anywhere from 1,500 to 3,200 rupees based on the company that makes it, whereas olanzapine is just 5 rupees. So that is the difference in cost that we can make to our patients. And I personally feel that nausea is an issue that is not being tackled with all the drugs that we have, and olanzapine is a good drug to tackle this. So a word about locally advanced squamous cell carcinoma of head and neck, which is an important issue in India. We have chemoradiotherapy as important backbone for us, but the survival needs to improve. And this led to the innovation and development of targeted therapies. And in 2006, we had two of these monoclonal antibodies, Rituximab and Nimetuzumab. I mean, Nimetuzumab is being manufactured in our own country. And this was our pilot study, which we actually published with a 5-year follow-up, showing that adding Nimetuzumab with chemoradiotherapy was in fact beneficial. Whereas if you remember, Cetuximab is a difficult drug to be added with chemoradiotherapy, and that is not recommended at all. We also started looking at 3-weekly cisplatinum versus weekly cisplatinum, and this is a paper we have published in head and neck cancers recently. And what we concluded was that 3-weekly and weekly were very similar in terms of outcomes, and probably the toxicity was slightly lower when weekly cisplatinum was used, and we could actually monitor these patients every week. So our contribution towards guidelines again, because these issues are our issues, and this is from the recommendations for head and neck cancers in Asian countries. Again, this is talking about weekly cisplatinum as a preferred alternative to 3-weekly cisplatinum. So in 2020, we brought out these guidelines, the Indian Clinical Practice Consensus Guidelines for Head and Neck Cancers. And this is a complete issue talking about each site in the head and neck cancers. And this is the algorithm that we have for oropharyngeal cancers. And if you see here, our own anti-EGFR monoclonal antibody finds its place in these guidelines. We get a lot of elderly acute myeloid leukemia patients who are really not fit to get intensive chemotherapy. So we did the study looking at non-intensive regimes that consisted mainly of HDAC inhibitors, and we published this in Annals of Hematology. Why I'm showing you this paper is the ASH 2020 guidelines looking for treating newly diagnosed acute AML in older adults have actually quoted our paper about the non-intensive regimes that can be used in elderly patients. So now ESMO has actually been coming to do a lot of guidelines, which are called the Pan-Asian guidelines, the PAGA guidelines, and ISMPO as a body have been involved in many of these guidelines, to name a few: breast, non-small cell lung cancer, and renal since 2018. And in 2022, we have been asked to be the lead in endometrial cancer for these PAGA guidelines. So I think that talks a lot about our society being positioned for these guidelines. We know immuno-oncology drugs have made a big impact, but again, the cost is an issue. So this is one of the papers which is going to be published soon in our own journal. And this is talking about consensus statement of Indian oncologists on the weight-based dosing of pembrolizumab. We believe that we can actually dose them based on the weight at probably 2 milligrams per kg and not a flat 200 milligrams. So this is, again, evidence to tell that we need to have guidelines very specific to our own disease problems that we have. Collaboration, I think, is very important for the futuring of oncology. And one of the important ones is to look at real world data and engaging clinicians in collection of the registry data. And this was the statement made in the ASCO post in 2016, talking about this very important issue of real world data. So this is our own Dr. Ramesh Nimagada, who is actually pioneering this database set called OncoCollect under his foundation. And he's got a lot of centers across India. And this is the map showing you all the centers that are involved in this collecting real world data, because what we see in randomized clinical trials may not really hold good for the what we practice routinely. And this data set has produced huge number of patients, as you can see here. And he's also shown the changes in the trends over time from 1996 to 2017 of various cancers. And this is specifically looking at breast and cervical cancer. Now, a word about breast cancer treatment optimization. We all know about various genomic profiles that are there, Oncotype DX, Endopredict, etc. But none of them have a substantial Indian population. So for this, we have our own profiling called Can-Assist Breast, and we are actually pioneering to validate this in the SAARC region. So this is going to be how the work will be done. And this is some data to look at Can-Assist versus Oncotype DX. And they've shown that there is 83% concordance of these two tests in low risk stratification. Recently, this data set has been validated in the Netherlands patient population, and that is going to be published soon. Now, why is all this important is because the doubling of medical knowledge in 1950 was 50 years, in 1980 it was 7 years, in 2010 it is 3.5 years, and in 2020 it is 73 days. So unless we collaborate, we are updated, we are lost in treating our patients. So collaboration, interacting with other bodies becomes very, very important. And as our conference has shown, we are collaborating with ESMO and ASCO. And I think this is very important to update ourselves with the latest knowledge that is there. Capacity building, I showed you that we have shortage of the workforce, and this is very important. And this is just to show you that ISMPO has in fact tried to help the local SAARC countries as well. And this is some of the preceptorship programs that we have done. We did 2 preceptorship programs in lung cancer in August 2020. One was virtual and one was face-to-face. We also did one breast cancer education conference in 2020 of November. And this has actually helped these region oncologists to update themselves. And so hopefully we will continue this in the future. Palliative care again is very, very important because most of our patients come with advanced cancer. So in partnership with SIPTA Palliative Care, this is the impact training course that we rolled out in Jan 2021. Subsequently, we have done many more, and it's been accepted very well. So progress, as I said, depends on collaboration. And as this old African proverb says, to go fast, go alone, but to go far, go together. So that is important that all of us come together and look at very innovative ways of how we can treat our cancer patients based on the specific problems that we have, and we only can make our solutions possible for our patients. With that, I will stop and thank you very much.